Hi, good morning, everyone. I'm Ranjan Duara, and welcome to all of you. This is our 10th MCI Symposium, so it's our anniversary, and we have come a long way, I think, and it's been a lot of fun. And I think that we're going to go on for the next 10. And like most anniversaries, one has to have a card involved, and we always change what we think about what we're going to say, so just put that one up for you. This is, of course, the theme of this symposium is atypical forms of Alzheimer's disease. And this is probably the most appropriate place to have such a conference, because Miami Beach tends to be somewhat atypical in many different ways. So the theme for this symposium was generated by a lot of interest recently in novel mechanisms for the disease that seem to be emerging, as well as clinical syndromes that are getting much better understood that are not the typical presentations of Alzheimer's disease. And we have a wonderful array of speakers today to discuss this, these various issues that I've been pointing out. But in general, the question is, what can we learn from studying atypical presentations of a disease? And how does that lead us to understanding the disease better, to, excuse me, sorry, Al. How does that lead to new concepts about disease pathogenesis? Well, we can learn a lot from our patients with atypical features. We can evaluate the atypical symptoms, signs, and biomarker profiles, and associations with risk factors. And this can then lead us to hypotheses that could tell us more about these atypical features and provide new interpretations about disease mechanisms. Taking the example of coronary artery disease, women are often considered to have atypical symptoms, and it's only atypical because men tend to have coronary artery disease much more frequently, as you all know. And so the symptoms that women have, which are less frequent, are considered atypical. They're not really atypical, but they're different, I should say. And what are these atypical symptoms? Fatigue, dizziness, back pain, non-exertional chest pain, and also atypical test results. Many women who have coronary angiograms, the reading on the angiogram is normal. They also have atypical risk profiles. For example, the inflammatory markers are much more important for women than they are for men. And hypertension and hyperlipidemia are much less important as risk factors. Coronary artery calcification is a more important risk factor for women than it is for men. The incidence of sudden cardiac death, which was very frequent in men, has gone down dramatically. But this same decline, even though women have coronary artery disease and sudden death much less frequently, the incidence, the rate, has not declined very much. And that could be because the emphasis has been on the traditional risk factors. These give us some clues about what might be happening in Alzheimer's disease too, as atypical symptoms occur and lead us to new hypotheses. So what are the mechanisms that seem to arise from investigating these atypical symptoms and presentations of coronary artery disease in women? Well, first of all, it was discovered in trying to figure out why the clinical syndromes went in that direction, that diffuse coronary artery narrowing rather than focal obstruction was much more common in women. And that might lead to different symptoms. The typical exertional symptoms that, that men have are not seen that frequently in women. And that's possibly because there's diffuse coronary artery narrowing, which reduces blood flow to an equal extent as a focal narrowing, but the symptoms that emerge are different. Immune mechanisms and inflammation are much more common risk factors for women. We know already that women have a greater tendency to have autoimmune disease, and so that plays out with coronary artery disease as well. Depression and stress-related hypoestrogenemia contributes to risk for coronary artery disease, and it doesn't seem to do so very much for men, or much less frequently. So these are some of the mechanisms that emerged by looking at these so-called atypical symptoms for coronary artery disease. And so this was the sort of model for what we thought might be the lessons that we would learn from studying atypical features of Alzheimer's disease. Amyloid deposition in Alzheimer's disease is usually symmetrical, but structural, metabolic, and cognitive asymmetry in Alzheimer's disease is very well known. Focal patterns of Alzheimer's disease may be associated with distinct clinical and demographic features and even genetic features. For example, some of the things that we can learn about asymmetry, this is a case where you see relatively subtle asymmetry of the brain. The left side, which is the left hippocampus, excuse me, this is actually very, very subtle asymmetry, but typically looks like a pretty much normal scan. Now, if you go to the next picture, the hippocampus on the right side of the picture, which is, excuse me, as you're looking at it on the left side of the picture, is much more atrophic than the right side. And the entorhinal cortex, which is, oops, excuse me. Can we get back to that? Right. The entorhinal cortex is also quite atrophic on the right side of the picture. But what you also see is that there is a here's the hippocampus, here's the entorhinal cortex here. What you also see is that the Sylvian fissure here is enlarged compared to the other side, and that the superior temporal gyrus is somewhat smaller compared to the opposite side. So there is a suggestion that the initial asymmetry that seems to have occurred on one particular side propagates along the same side. And this might be more evident in the next picture, where you also see, in addition to the asymmetry of the hippocampus here and the entorhinal cortex compared to the opposite side, and a very thin superior temporal gyrus, a very enlarged inferior ramus of the Sylvian fissure, that there's also a little bit more asymmetry of the cortex as well, and the lateral ventricle is somewhat larger as well. So there's a suggestion of progression of this asymmetry, and that might lead us to certain hypotheses about the disease and mechanisms related to the disease. The pattern of structural asymmetry in Alzheimer's disease seems to be most severe in the medial temporal regions, but atrophy then seems to extend progressively to the neocortex. And that essentially is the backdrop for this symposium.